exam tips. Yes. So let's share the screen and start, inshallah. I hope everyone is the screen is okay. Yes. So maybe until we'll just reach our target. Yes. So the voice is clear and everything is fine. Let's have a look in this images. Sure that when you see such a sagittal image, you are searching for the meniscal tears or any injury for the menisci, and also for the ligaments injury, right? So what do you think about here for just this selected images? Do you think that there is something going on in the... Yes, I see that maybe still I should wait until someone is, yeah, to tell what could be. Let's join and chat together and try to figure out, yeah. So yeah, ACL tear, I think that you can see that the BCL here is intact, but the ACL here is already disrupted and high signal. Yes, and you can see, yeah. So when you see this image, you are searching for the other manifestation that maybe could include meniscal tear, right? Especially the medial meniscus, right? So do you think that the medial meniscus in this case is, yeah, you see already the ACL is injured, yeah? So do you think also that the medial meniscus is torn here? Okay. So what do you think about this sagittal images? Yeah. So this is the medial meniscus posterior horn, and probably the selected images here with the anterior horn, it doesn't appear plus the body, yes. So you cannot see clearly the parts of the meniscal, of the medial meniscus, right? So you are talking about, yes, what is called unhappy triad, yes. When you find the ACL tear, you search for the other association, which is the medial collateral ligament and the posterior horn of the medial meniscus. So what do you think about here? Yes, here. So you should search for it to find it easy. It was present before, so don't misdiagnose it or miss such lesion. Yeah. So this is the medial collateral ligament, and you cannot see it well. You cannot see even the fibers of this medial collateral, right? So let's go more further and see this patient. I think maybe I got to the answer, but okay. Let's try to think what could be the differential and where is the pathology. So when you see the pelvis of young or child patient, so you are thinking about either slipped capital femoral epiphysis, like the previous session, or maybe DDH, one of the differential. But if you check the points of DDH, developmental, yeah, you will not find that could be developmental, right? But what could be here? I mean, if you look in the joint space here and compare it with the joint space here, is it similar or there is Maybe some widening here. Do you think so? So if you find this Shinton line already, like if you try to draw it, is not very interrupted. Maybe it's a bit far from the what it should be here, right? But what is more, that the joint space here, yeah, it looked like a dislocation, but more than dislocation again, and this is the child, and it should be like when you find this, you are in something like emergency. Perfect. Yes, Dr. Zuhair. So this is joint effusion, and the most important exclude if this patient have, yes, septic arthritis. Exactly. So you should emergently go to further ultrasound, and any effusion, yeah, you are checking for septic joint, and if this patient didn't diagnosed well, you will lose this joint. So this is very critical to mention, that one of the most important, that's the septic arthritis. Sure that you can include other differential, but the septic arthritis should be in your top differential, right? If you want to check the MRI, have here one picture for MRI, which is in the post contrast. You can see how the enhancement, the effusion, you have full picture, but not all the patient you can do for them MRI. So ultrasound and X-ray is important. So let's have a look in this case. We already mentioned some spine when we're in the neuro session, right? Yes. So what do you think about here? Yeah. Okay, let's go to the answer. Maybe you will think that maybe there is osteophytes here and there is some degenerative disease. Okay, but what else? What you should see in the checklist that you will search, and you will search for something. Yeah, disk space. Sure that you, it is not just normal degenerative changes, or sorry, regular degenerative changes, maybe more, right? So you are going to think about septic, maybe. So we give you another clue. Let's have a look and try to figure out what it could be. Maybe, but it doesn't look like bamboo. Bamboo is like something different. If someone want to talk or discuss verbally, you can just unmute himself and okay. So let's have a look in this. This is a bone scan, and I think now is a bit more obvious what could be. Yes, I am waiting to, when you find this bone scan with this appearance, this is characteristic to be, yes, Honda sign. So this Honda sign, don't forget it, because always when we see this image, we are thinking about degenerative spine, and it's important to know the history. This patient, for example, underwent, yes, something like radiation or any sort of stress or steroid uptake, or so insufficiency fracture, which produce with you this, or stress fracture, which show you this Honda sign. This is very important. They like it in the exam as one of the common places for the, yes, stress or insufficiency fractures. Yeah, you can see here in the, when the patient did CT, that already he have this appearance. Yes, so you can see the fractures here easily. Even you can see these fractures, right? So this is what is called sacral insufficiency fracture. As he mentioned, it's very difficult sometimes to detect in X-ray, as what happened with us. Maybe you can find some sclerosis, and this is the golden eye. Here, the role of the golden eye, when you have your golden eye, then you can reach it easy. But okay, bone scan, this is the most important to know what is called Honda sign, which I show you. And sometimes it could be unilateral. Okay, sure that the CT will be the best. When you find the prosthesis or any metallic, yeah, you will think about another checklist, including the normal checklist or regular checklist that you are going to check about the cortex, soft tissues, joints, one by one, okay? But you will add what is linked to the prosthesis. So either you are going to find complication for the prosthesis, like loosening or fractures or infection. Yes, so perfect. One of the most important to know about complication of the prosthesis, something called particle disease. Yeah, especially when you find this appearance with the lytic. Yeah, with the lytic appearance. Sometimes the loosening may be the complication, but here you cannot see any loosening, and they have like check regions. You should show that there is no loosening any area along the prosthesis. Perfect. So what is particle disease? Yes, it is granulomatous reaction. Perfect. So the complication that could be present, the loosening, and the loosening is more than 2 millimeters. Okay, and one of the complications is called migration and cement, or yeah, periostitis. Yes. So particle disease, which is some sort of aggressive granulomatosis, which presented by lytic lesion, as we see. Okay, so yeah, this appearance, you find like this osteolysis. Yes, so this is what is called particle disease. Yeah. Okay, sure that you will check for infection, as we mentioned, and sometimes it require aspiration. Yeah. Let's take another case which have this appearance. So we will go to our scheme. Is it a bone? Is it soft tissue? Is it a joint? So it appears like it's a bone lesion, right? Bone lesion. So if it is bone lesion, you will have like a 5 points you should comment on it. Starting from, yeah, aggressive or non-aggressive, yeah, what it look like, aggressive, yeah, aggressive. Why aggressive? Yeah, one of the important things, yeah, pre-osteal reaction and long, short zone of transition or wide zone of transition appear like wide zone of transition. It is not like short zone, right? It is wide zone. You cannot recognize which area could be the normal one, and after that it become abnormal, right? So you have here appearance of, yeah, the osteal reaction, which look like aggressive the osteal reaction, and probably there is soft tissue. You need to check for MRI. Yes, and yeah, so it look like aggressive lesion. One of the best differential that you include Ewing sarcoma. Could be, you can put osteosarcoma, eosinophilic granuloma, but it's more lytic infection, which is important that you sometimes you cannot differentiate between infection and Ewing sarcoma. Yes, Also lymphoma, leukemia, and metastasis. So as we mentioned, the pattern of this lesion is it moth-eaten, permeative, which wide zone to transition and have aggressive reosteal reaction and soft tissue mass. Yes. So this is the character of some information about Eosinophilic. And here, as you know, when you find the bony lesion, you should ask or try to find a key in the case about the age. If you find something that tell you the age, then almost you have the answer. Okay, so Eosinophilic come in the second until the second age, yes, second decade. It present by sometimes with inflammatory appearance, so it can have the similar to osteomyelitis. Yeah, someone is drawing something. Okay, thank you. Sometimes diaphyseal, metaphyseal, okay, central within the bone. I like just to know that some of this information can come to you in MCQ. That's why I try to read with you to just make some review. Osteosarcoma, again, is similar to the age, but more younger. Remember that the multiple myeloma but it come in the older age group. So, and also here it like to be metaphyseal, yes. And permeative, wide zone of transition again as any aggressive lesion, and the rest of, yes, aggressive characters. Here you have this escape lesions, which is important in MCQ. When you find, you will search for them. And yes, maybe also to be mentioned that it make what is called pneumothorax, that the osteosarcoma metastasis in the lung is much characterized by pneumothorax. Okay, so this is the MCQ questions. Let's go to eosinophilic granuloma as one of the most important differential diagnosis. It can look like anything. You can put in any differential diagnosis as a bony lesion under age of 30. So you have now metastasis, lymphoma, and eosinophilic granuloma, especially for age under 30. Again, it have appearance of aggressive, but sometimes it can have narrow zone of transition. Okay. As we mentioned, this is the differential diagnosis, and don't forget infection as one of the important differential diagnoses. Here, some appearance of eosinophilic granuloma. This is what is called vertebra plana. I think less than 1 minute it will close, so we will go again. We'll restart again just the Zoom and come back. And this is how it looks with aggressive behavior in the bony, long bone lesion, yes. And this is the baton sequestrum or the lytic appearance in the skull, yes. Differential diagnosis, sure that it will include osteomyelitis. Osteomyelitis can behave like everything. You put in the